So welcome everyone, and thank you for joining us at this Tuesday lunch with EUROFEVER webinar that today is about the role of interleukin-1 in Kawasaki disease, basic and clinical implication. My name is Teresa Gianni. I'm pediatric rheumatologist in Florence, Italy. I work at the Anna Maria Children's Hospital. And I have the pleasure of moderating this event alongside Dr. Federica Anselmi. We are honored to host two outstanding speakers that will provide us with an overview of the key role of interleukin-1 in the pathogenesis of Kawasaki disease. And I also explain us the clinical implication of its therapeutical blockade. This will be a valuable scientific opportunity, so please, we want to encourage you to participate with comments and questions. Do use the question tab, which you can find on the right side of your screen. You can use it at any time during the presentation, and of course, at the end, during the Q&A session that will follow the end of both presentations. And also let us know where you are joining from. So we are going to start with the first speaker, that is Christophe Cassel. He is the leader of the unit of transitional inflammation research within the Department of Pediatric Rheumatology and Immunology at the West Philippe Wilhelms University in Münster, Germany. His research focuses on exploring novel inflammatory mechanisms at the biochemical and cellular levels, with a strong emphasis on multidisciplinary and transitional approaches. His team investigates disease mechanisms and biomarkers in the context of still disease and associated complications. So welcome, Christophe, and the screen is yours.
Thank you very much, Teresa, for this really nice introduction. I am starting to share my screen. And as we just had some issues there, I hope it will work. You can still see the... So now we should have moved to presentation mode. If that is not the case, please say the word, because then otherwise I will take it away. I've been asked to talk about the pathogenesis of Kawasaki disease, and I added this extra line, where exactly are we? Because I believe this is a really wide topic to cover in 20 minutes. I will do my very best to highlight a few aspects here. These are my disclosures, and the disclaimer for this webinar is, at least from my side, is that I am not a Kawasaki disease expert. As you heard in the introduction, we focus on Still's disease in our research mainly, but I also think that this is also a feature of Kawasaki disease. Who is actually an expert? This is a pediatric cardiologist, this is an infectious disease specialist, this is the pediatric rheumatologist. I think some of that this is also what renders Kawasaki disease so interesting and fascinating. I think this is from different perspectives, that it can still be considered a quite mysterious disease. One of pediatric medicine's greatest mysteries, as titled here by the New York Times in their 2024 article on Jane Burns, who's probably the one and only true Kawasaki disease specialist on the planet. Now, when compiling this webinar, both Isabelle and I thought that it might be good to include one very basic background slide on Kawasaki disease. I know you're probably all familiar with it very well, but just to put all of us on the very same page. The disease is named after Tomisaku Kawasaki, who initially described 50 cases of mucocutaneous lymph node syndrome that he proposed as the new disease. However, already in the 19th century in Western countries and in the 20th century in the US, there were reports on a disease that was called polyarteritis nodosa, and later on periarteritis nodosa of infancy, that pathologically actually turned out identical with Kawasaki disease. So name branding of the disease in Japan. Japan is still the country with the highest incidence rates, but in fact it is really a global illness. Kawasaki disease is an acute vasculitis of early childhood, which predominantly affects the coronary arteries. Until today, there is no designated diagnostic test, which significantly hampers its early diagnosis, which on the other hand side is so important to prevent coronary artery damage, because those already occur very early in the disease phase. Until today, intravenous immunoglobulin injections is the mainstay of the treatment and have proven effective, but not entirely effective in preventing coronary artery aneurysms. It's also a quite expensive treatment and not available in all regions in the world. If medication cannot successfully prevent coronary artery aneurysms, there is a significantly increased risk for long-term cardiovascular complications, which in the end renders Kawasaki disease a leading cause for acquired heart disease among children in developed countries. Now, in the grand scheme of the disease pathogenesis, today the mystery aspect regarding Kawasaki disease mainly accounts for its unsolved etiology and potential environmental triggers. And people get into airplanes and fly around with air filters here around Mount Fuji to collect whatever fungi, spore may be able to associate with disease outbreaks. Beyond that, I think we meanwhile do have some good understanding on potential genetic predispositions that are involved in the pathogenesis. There is also a link with self molecules that are related to cell damage and stress. And that all together may then orchestrate mainly innate, but also adaptive immune mechanisms that then ultimately drive cardiac inflammation as the clinical hallmark feature of Kawasaki disease. Now, with respect to the mysterious etiology, one slide. What do we actually know until today? Well, following the first record of Kawasaki disease-like cases in Japan in the 1950s, and following several wars and occupational scenarios, there have been three major Kawasaki disease outbreaks, which to infectious disease specialists clearly tell that there must have been a causative agent that has been introduced in an otherwise highly genetically susceptible population. Ever since, the incidence rates, particularly among young children, have been remained fairly stable. Can you still see my slides moving? Yeah, okay. Have been remained fairly stable. However, there has been an increase, about fivefold increase, particularly among children at preschool age and at school age, which is completely not understood until today, and which has fueled speculations that there must have been some agent that's been introduced, eventual wind-borne agent that has been introduced into Japan. But until today, it is actually completely unclear what that should actually be, whether that's Candida species that are carried into Japan from northeastern China, whether this is fungi or spores that are carried with western winds and that have increased with an accelerating climate change. However, beyond that, there is also evidence that an aerosol-borne respiratory trigger may operate as disease trigger. There are data that Kawasaki risk is lower if children are firstborns. It increases if there are several siblings in a household, and it's highest from the youngest. Again, decreases if those attend daycare. There are breastfeeding data that argue for a protective effect, eventually mediated by maternal antibodies. And finally, the hygiene measures that were introduced during the COVID pandemic showed, like for many other diseases, that the incidence rates went down, but they never dropped as much as that was observed for true respiratory diseases. Now, while a role for a potential causative agent still remains quite unclear, there is quite broad consensus on genetic contribution due to Kawasaki disease pathogenesis, already told by the fact that the incidence rates in Japan as a genetically distinct population are the highest. Until today, there have been several SNPs that have been identified in Kawasaki disease, but overall, those have demonstrated to have only quite modest effect size. Of those single nucleotide polymorphisms, actually only polymorphisms in the inositol triphosphate 3 kinase C and caspase 3 have been. Sorry, the screen moves really slow. And the Fc gamma receptor 2A have actually been validated in independent cohorts. Interestingly, now also in context of this webinar's topic, polymorphisms in IT, PKC, and RA1 and SLC8A1 have been linked to intracellular calcium flux, which in turn may associate with increased NLRP3 inflammasome activity. And it was these sort of genomic data as the first ones to possibly link also with elevated IL-1 expression, which promoted also these data to be highlighted in a respective Nature Research article. Now, inflammatory cytokine expression, inflammatory activation of immune cells, including inflammasome activity, can also be driven by cell molecules related to cell damage, so-called DAMs. And in contrast to apoptosis, which is hallmarked by an organized and silent and clean clearance of cells, particularly in the course of necrosis, which is comparably loud and ugly, numerous molecules and proteins otherwise residing in different cellular compartments can be released all of a sudden and can hit several pathogen recognition receptors and activate immune cells, but they can also be recognized as autoantigens. As two examples of such DAMs that also have a relevance in Kawasaki disease, that is ATP and S100 proteins. Of those S100 proteins, S100A12 in particular is a protein that is predominantly expressed by human granulocytes and resides in the cytosol, where it constitutes about 5% of the total protein. It belongs to the calcarenin protein family, together with S100A8, A9. These proteins can actually bind different bivalent metal ions, but their cellular function intracellular function is until today in fact quite unclear. Now, in connection with endothelial cell activation in Kawasaki disease and breakdown of that endothelial barrier, it was already suspected almost 20 years ago that S100 proteins that are released by myeloid cells can bind to different cellular receptors and thus may be directly involved in the vascular endothelial activation. So those considerations were fueled by expression data, gene expression data that demonstrated massive overexpression of S100 proteins in cells isolated from Kawasaki disease patients, but also by data that demonstrate S100 levels in serum in course of IVIG treatment, and that showed that in responders, initial levels were lower compared to IVIG non-responders, and also declined rather rapidly in course of therapy, while this was not or significantly less the case in IVIG non-responders. Now, in context of determining what stimulus S100 proteins could actually provide, what inflammatory stimulus they could provide, we already a while ago reported that these proteins are able to signal through the TLR4 receptor, and for S100A12 in particular, we found that its alarmin function is actually encoded by the protein structure, meaning that when the protein is released from cells, it gets in contact with extracellular ion concentrations, resulting in its oligomerization. And it's basically this transformer-like behavior that ultimately enables the protein to bind and signal through the TLR4 receptor and trigger a sterile inflammatory response, including expression of IL-1 family cytokines. However, when we tested whether S100A12 could actually have a direct role in the inflammatory activation of coronary artery and endothelium via this TLR4 path, as it was proposed for Kawasaki disease pathogenesis, the answer to that question was actually no. Because we observed that these cells, so coronary artery endothelial cells, lack an important co-receptor to TLR4, which is CD14, and that is particularly important for S100A12 signaling. However, we can sort of install the sensitivity of these cells to respond to S100A12 if we transfect them with a construct that enables the cells to express CD14. What we, on top of that, observed is that if we perform such stimulation experiments together with the human monocytes, we could see that the S100A12 protein could activate these human monocytes via TLR4, and together with ATP, that activated the NLRP3 inflammasome and resulted in an IL-1 release. And in fact, we observed that human coronary artery endothelial cells were highly responsive to IL-1 stimulation, which we could also observe on the level of their sensitivity to IL-1 blocking treatment. Now, next to S100 proteins and S100A12, in particular, Kawasaki disease neutrophils are not only packed with those proteins, but they're also loaded with IL-1 beta, and that is already the case ex vivo. So without an additional stimulation, Kawasaki disease neutrophils carry a lot of IL-1 beta with them. And what the authors of this paper further on observed, and maybe that's even more striking, is that if you, in course of IVIG treatment, these cells, particularly these cells, are driven into a rapid apoptosis independent cell death. So among the many modes of action that are proposed for IVIGs, this adds actually a direct targeting of IL-1 expressing cells as one of those mechanisms of action. Now, altogether, all these data directly feed into an accumulating evidence for a prominent role of IL-1 beta signal in Kawasaki disease pathogenesis, and this involves genetic data, as already previously discussed, but also blood transcriptomic signatures from Kawasaki disease patients, which show clear upregulation of all sort of players that are required for enhanced IL-1 expression and signaling. And on top of those, in patient data, there is also a massive amount of data acquired from Mura and Kawasaki disease models that demonstrate a high sensitivity to IL-1 blocking treatment and in these different models. Most of these data have actually been acquired in the LCWE model and by the team of Marshall Arditi in San Diego. And this model is actually induced by a quite heterogeneous stimulus. So this is Lactobacillus casei cell wall extract that is injected to these mice, and then it's been shown that recapitulates quite some features of Kawasaki disease-specific cardiac inflammation. This model has been shown to acquire myeloid cells and mediated signaling. It requires the expression of functional TLR2 and TLR4, while the acute phase in this particular model is actually has been shown to be T-cell driven. Interestingly, the model also seems to recapitulate the slight sex bias of Kawasaki disease. So male animals seem to be more affected here, and that can also be linked to heightened IL-1 expression and signaling. Next to the LCWE model, the chaos model is also induced by a very heterogeneous stimulus. The Candida albicans water-soluble fraction is injected here repeatedly to these animals. This is a B cell and T cell dependent. It operates actually independent from T and B cells, in contrast to the LCWE model. But also in this model, IL-1 has been shown to have a prominent role in driving the disease. But next to IL-1, there are also other effector cytokines that have been shown to have different roles as primers and drivers of cardiac inflammation. Now, aside of all these pretty targeted and in part hypothesis-driven preclinical and in vitro and in vivo studies, over recent years, there have also been an increasing number of omics studies in Kawasaki disease that may also help to better understand underlying immune perturbations, including an intertwinement of innate and adaptive immunity in the pathogenesis. Now, in these lines, a fairly recent peripheral blood single-cell study in Kawasaki disease patients before and after IVIG treatment basically confirms a number of previous data at high resolution. Specifically, the data from these studies demonstrate an extensive depletion of T cells and K cells in course of the disease, with the exception of a few isolated subsets. They find an increase in B cells, which is mainly attributable to an expansion of plasmablasts, and they find a heightened elevated level of monocytes that carry a pronounced inflammatory signature that is hallmarked by overexpression of S100 proteins, IL-1 and TNF. In terms of serum proteomics, particularly in comparison with MIS-C, there have been several studies, including our own, that highlight IL-17A as one distinct cytokine hallmark of Kawasaki disease. However, with respect to IL-17, the question is which cells do express these cytokines actually in the disease. There are some beautiful data that demonstrate priming of Th17 cells in the gut, which then migrate into cardiac tissue, and then via cross-reactivity to cardiac myosin, they can drive myocarditis. Yet in Kawasaki disease, it may actually be questionable whether the observed elevated IL-17 is actually Th17 derived. If we look at the data from the single-cell study that I just pointed out, you can see the S100 protein expression significantly upregulated in monocytes. We can see the same for IL-1 and for TNF. But if you look at IL-17 in the CD4 T cell compartment, there is actually only very little expression, and it's definitely not significantly elevated, at least in the subset of patients that's been studied here. Now, in contrast to Th17 cells, previous studies already highlighted the expansion and activation of particularly gamma delta T cells over other T cell subsets in Kawasaki disease. And in systemic JAA, we have already demonstrated that S100 proteins can actually activate monocytes, and those can drive IL-17 expression from gamma delta T cells, where IL-18 is promoting cell expansion and IL-1 is driving IL-17 expression, and this can be abrogated by introduction of, or by blocking the IL-1 signaling to the gamma delta T cells. And also of note in this context that gamma delta T cells represent a prominent, if not the major source of IL-17 already at very, very young age. And in contrast, Th17 differentiation capacities develop a little later, and then the cells retain a quite prominent immunosuppressive capacity for up to 12 months of age. Now, we already talked about some aspects of Kawasaki disease-specific cardiac vessel inflammation in context of the targeted experiments on endothelial cells. And as a last point in this presentation, let's take another look at this from an omics perspective. There has been a very recent single-cell seq study in Kawasaki disease patients with and without coronary artery lesions. And in this study, the authors report generally decreased lymphocytes. So again, confirming previous data, generally decreased lymphocytes populations, but they find expansion of myeloid and megakaryocyte cell populations in Kawasaki disease. Particularly among patients with coronary artery lesions, they observe exhaustion phenotypes among NK cells and CD8 T cells. And they also report elevated expression of a lot of MMPs and inflammatory cytokines, including players of IL-1 along the IL-1 signaling path, predominantly from monocytes and also from megakaryocytes. We recently also performed a broad serum proteomic study in treatment-naive Kawasaki disease patients compared to healthy controls that was targeted at cardiovascular markers. And we found a signature of upregulated proteins related to fibrosis, arteriosclerosis, and endothelial to mesenchymal transition, particularly in Kawasaki disease, compared to a downregulation of proteins that modulate cell-cell contact or that can inhibit fibrotic and sclerotic processes. Now, endothelial to mesenchymal transition can actually be a consequence of inflammatory activation of endothelial cells. It is governed by TGF-beta signaling, but also by MMP expression. And remember the single-cell study data I just showed you, where they find those elevated in patients with coronary artery lesions. And then the endothelial to mesenchymal transition results in a breakdown of the endothelial barrier function and ultimately can destroy the vessel wall integrity. And in Kawasaki disease, it has already been recognized as an important process in context of cardiac remodeling and cardiac fibrosis. Now, on top of the proteomic data, ex vivo data we generated, we also observed that if we expose human coronary artery endothelial cells to a highly diverse inflammatory matrix, that induces inflammatory activation of the endothelial cells and in turn induces endothelial to mesenchymal transition. And this process can be best reverted by IL-1 blocking over TNF blocking treatment. So taking all these in vitro, in vivo model, and in patient data on different Kawasaki specific pathological aspects together, there is up until now, I think, a real major body of evidence demonstrating a prominent involvement of excessive IL-1 expression and signaling in Kawasaki disease pathology. I think it might actually be even more evidence than we have in systemic GAA, which we today clearly accept as an IL-1 driven disease. And whether the question mark needs to remain here, I think probably the best way to answer that questions are IL-1 targeting trials in Kawasaki disease and the data that Isabelle will discuss with you next. Of course, all the data that I showed you from us involve many people. Our Kawasaki disease studies are always done together with Andre Jakob in Munich, who's a great collaborator in this, but also Ulrich Mainzer and Isabelle Melki have been of tremendous help in putting all this together. That's it from my side. I think we take questions in the end. Thank you.
Okay. Yes, thank you, Christoph, for sharing your experience with us and for your amazing presentation. And hi, everyone, I'm Federica Anselmi. I'm a pediatric rheumatologist at Bicêtre University Hospital from Paris. And today I'm really honored to introduce the second talk of the day by Professor Kone-Paut. As most of you know, Isabelle Kone-Paut is our leading expert in pediatric rheumatology. And she is actually the head of pediatric, a renowned department of pediatric rheumatology in Paris at the Bicêtre University Hospital and University of Paris Sud-Saclay. And her work spans clinical care, research, and advocacy for children with autoinflammatory and autoimmune diseases. And together with her team, which sees over 300 patients with autoinflammatory diseases annually, she developed the AIDAI score, which is the first disease activity score for autoinflammatory diseases. And moreover, since 2006, she has led and contributed to over 30 clinical trials. And finally, today, she plays a key role in several international collaborations, such as EUROFEVER and IMMUNAID. And last but not least, she's not only a brilliant expert, but she's really very fun. So I can confess she's a mentor for me. And by the way, before handing over to Isabelle, I just want to remind you to not be shy, to interact and to ask your question to the question and answer tab. And of course, we'll have the time to discuss after the talk. So now, Isabelle, it's your turn. Are you ready? You have to turn on your microphone. Maybe.
Yes, you can hear me?
Okay.
Yeah.
We can hear you.
So can you see my screen? Can you see my screen?
Yes. Not the presentation, but the screen, yes.
Ah, not the presentation. Okay.
You have to open your presentation.
Yes. Okay. So maybe I may ask our moderator to show my screen. I don't know where she is to show my presentation. Okay, so I think now that everybody can see it. So sorry for this. So thank you, Federica, for your kind introduction. So now we're going to see together the implication of the role of IL-1 in clinics. So next slide, please. So as you know, the first line treatment of Kawasaki disease is on IVIG, and there is strong evidence to use this treatment. It's very effective if we give it before 10 days of fever. And it has been demonstrated that along with aspirin, it could reduce the incidence of coronary artery aneurysm. So it's really a very important treatment that has changed the face of Kawasaki disease, but there are 20 to 30% of patients who are resistant to this treatment, and these patients have a high risk for coronary aneurysms. So now we have really a very important question, and we have to think that aneurysm prevention is a primary goal of treatment during the acute phase of the disease. Next slide, please. So this is a study that has been conducted in Los Angeles, and you can see here that we have now some indication that some patients specifically are of high risk of developing coronary arterisms. And so if you look on the left, you can see the natural history of development of this coronary aneurysm, and you can see that they are very frequent in the initial phase and up to 5 weeks of evolution of the disease. So we have to consider this, that the risk can last for several weeks between the onset of the disease and the last follow-up. And then also you can see that the age of the patient is very important, and that the risk of developing large aneurysms is correlated with a lower age. So this is also something important to consider. Also, the timely treatment to the IVIG is very critical because if you add more days to start the IVIG treatment, your patients have more risk to develop coronary aneurysm. And also the level of inflammation as reflected here by the level of albumin. So what could we do? You can see next slide now. So what can we do after this? So next slide. So we had a good demonstration that IL-1 is critical in the development of Kawasaki disease and in endothelial lesions. So in addition to this, I have to say and ask you a question. You can see here that you have some kids with, inflammatory disease with, skin rashes. So to your opinion, which patient has Kawasaki disease among them? They are really indiscutible, and in reality, none of these patients has Kawasaki disease. But they have other diseases that are IL-1 driven, and in most of these cases, you have patients with monogenic diseases that are related to IL-1 secretion. So really, Kawasaki disease on a clinical evaluation really look like this disease, and it can show that IL-1 is important. Next slide. So to go further, so we have to assess how we can block the IL-1 in Kawasaki disease. So as pediatric rheumatologists, we have a large experience in using anakinra. So anakinra has been used in monogenic systemic autoinflammatory disease with high safety profile, because this molecule has a very short half-life, and it's also a potent blocker of the IL-1 receptor. And by the way, it can block both the IL-1 alpha and the IL-1 beta. So most experience we have with this medication is to giving it by subcutaneous administration, and with doses that can go up to 10 milligrams per kilo. Next slide, please. So there was a first evaluation of the safety of anakinra in Kawasaki disease. It was a trial that was conducted in San Diego, the ANAKID trial. And it was a phase 1/2A dose escalation study of anakinra, which was used from 2 to 11 milligrams per kilo per day in 22 patients who had acute Kawasaki disease, but who had also large coronary aneurysms. So anakinra was given up to 6 weeks, And in this experience, it was safe and well tolerated by the 22 participants. And you can see that they were very young patients because the median age was 1.1 years. So those patients have a lot of co-treatment. All these patients had been treated with IVIG. 20 had also received infliximab at 10 milligrams per kilo before the initiation of anakinra. So in this experience, and this is very interesting, they use both IV and subcutaneous anakinra. And the use of IV anakinra is something that is really interesting because one inconvenience of when you use this drug is the subcut administration is painful. And when you have a child who has a weight that is rather important, you have to use important volumes. So it may be really a barrier for the use of anakinra by subcut administration only. And what they observed and what is their conclusion in this study, that if we could use IV dosing every 8 to 12 hours during the acute phase of CADE, it could allow sustained concentration while avoiding frequent subcutaneous injection. So it was the first experience, and to my opinion, it's something very interesting to consider and maybe to pursue. Next slide, please. So from our part, we have done the Kawasaki trial. So it was really a multi-center, open-label, single-arm, proof of concept, very short study. And the patients were maintained in the study for 45 days. And our aim was to evaluate the efficacy and safety of anakinra in patients with Kawasaki disease who failed to respond to IVIG. In this trial, they could have received one or more courses of IVIG, but no corticoids were allowed before attaining the primary endpoint of this study, because really we want to observe the effect of anakinra alone. The primary outcome was the absence of fever within 48 hours of anakinra treatment, and we consider the last escalation dose attained for making this evaluation. Next slide, please. So you can see here the trial, how it was presented. So the recruitment duration was 3 years. And so when the patient could be included, it was maintained during 45 days. So the screening period was as short as possible, and though the patient could have the possibility to include the trial as soon as possible. So we wanted that the patient could not be included after 14 days of fever, because you know that the natural history of Kawasaki disease is probably the abatement of fever at some time. So it was important to have them. And also, we didn't want to have a patient that have too many long-lasting inflammation, because really it changed the fate of the disease. And then they could enter the disease if they have the criteria of inclusion, and then they received a first dose of anakinra. So at this time it was 2 milligrams per kilo, and if they have still fever after 24 hours, you could increase the dose to 4 milligrams kilos, and the maximum was 8 milligrams per kilo. For 6 milligrams per kilo for those patients who are more than 9 months of old, but for those patients who were less than 9 months old, the starting dose was 4 milligrams per kilo, and you could go up to 8 milligrams per kilo. So next slide, please. So you can see here the doses of anakinra that were necessary in those patients. That you can see that some patients, 4 patients, need 2 milligrams per kilo, a little more 4 milligrams per kilo, and more 6 milligrams per kilo. And you can see below the time to fever below 38 degrees after the last escalation dose. And in most cases, it was 48 hours, but in some cases, it was a little longer. Next slide, please. So you can see here the profile of the CRP. So you can see that most patients has very high CRP level, and it decreased rapidly during the first 7 days, and after it stabilized to attain a value below 6 milligrams per kilos at day 14, around day 14. And you can see also the evaluation of disease activity by both parents and physicians. And you can see that at day 14, in most cases, the PGR was at 1 or 0. Next slide, please. So here is the effect of anakinra on the coronary Z-scores. So you can see that at the screening visit, a number of patients had a Z-score at 2 or more. And you can see that after 14 days of anakinra, 60% of patients had a Z-score below 2, and it was stabilized at day 45. Unfortunately, we had one patient for whom anakinra was not effective, and it continued to increase its Z-score at day 45, and one patient had an increase and then could decrease a little and have a stability of its coronary Z-score. Next slide, please. So this is a study which has been done by the team of Christoph Kessel, and that can show you that during acute KD, there is an overexpression of innate mediators like IL-6, CXCL10, S100A12, and IL-1 array. What is really interesting there, that they could identify one protein, LRG1, which is an acute phase protein that modulates the TGF-beta signaling, which is very important in the endothelial activation. And we could show that LRG1 concentration was associated with persistent inflammation, and it was selectively in Kawasaki disease. It's not shown there, but especially if we compared with level of LRG1 in systemic GIA related macrophage activated syndrome or in MIS-C. And what you can see on the right, that the overexpression of this protein LRG1 in a subgroup of patients with enhanced inflammatory activity was largely associated with the need to increase the dose of anakinra over the course of treatment. So this was an interesting data. So next slide, please. So I show you an ongoing trial, which is ANACOM trial, that is also conducted in France, which is a 60-day randomized controlled open label trial of superiority of anakinra over IVIG with 2 parallel groups randomly assigned in a ratio of 1:1 and matching for age, gender, and drug status. So we have activated 13 French units, and the hypothesis is to expect a 30% difference in the response rate between the experimental group and the control group. Next slide, please. So you can see here the trial. So we want to include patients who have had a first line of IVIG and who do not have respond to this treatment. So the patients have to be included before 11 days of fever. So if they are eligible, they are randomized to receive either anakinra or IVIG as a standard care. So they receive anakinra during 14 days. The initial dose is 4 milligrams per kilo. And what is different comparing to the Kawakinra trial is that we aim to increase the dose every 12 hours if they are still febrile. So the escalation dose maximum is 8 milligrams per kilo. So the primary endpoint is a body temperature below 38 degrees within 2 days after initiation of treatment, and of course at the last escalation of dose of anakinra if we have done one. And for sure, we didn't want any use of corticoids before entering the study and before attaining the primary endpoint. Next slide. So after this, we are now conducting a retrospective evaluation on the use of anakinra for Kawasaki disease in France. So I show you only some interim analysis. Not all the cases are included, and it's ongoing with Caterina Matucci-Serenic and Perrine Dussert. Next slide, please. So we analyze patients that were included in the GIR cohort for 2017 to 2023. So we could identify 24 patients that received anakinra ever for Kawasaki disease. So their median age was 19 months, and the delay to first treatment of anakinra was 7 days, with some difference from 2 to 16 days. So the median duration of anakinra treatment was 14 days, and the median dose used was 6 milligrams per kilo with a mean of 5 milligrams per kilo. Those patients were severely affected because 87% of them had coronary abnormalities, and one patient had also severe myocarditis. You can see on the right the reason for introducing anakinra. It was either fever and biological inflammation, either fever, inflammation, and aneurysm, or the presence of aneurysms. Next slide. So global treatment that those patients received, so they had first-line IVIG in all cases. In the second line, you can see that they had either IVIG or anakinra in almost 40% of cases, and they could also have received corticoids in 25% of cases. On the third line, you can see that anakinra was used in 2 patients in the third line, and for the other on third line, most of them had anakinra added to corticoids. So we had not a lot of patients who had only anakinra, but most of them had a mix of other patients, of the treatment. Next slide, please. So you can see here the value of the CRP before anakinra treatment and after, so we have a striking difference, and also the number of neutrophils before and after the use of anakinra. Next slide. So, of course, this cohort was represented by relatively few patients. I think that now we have at least a double number of patients that are reviewed. But those patients were severely affected, and anakinra has been used essentially as rescue therapy and lately in the course of Kawasaki disease, and largely in association with corticoids. So it's really difficult to interpret. We have a follow-up of 18 months, and 41% of patients have sequelae, but only 2 have giant aneurysms, and 58% have normal coronary arteries, which is not bad. 5 have small and median aneurysm, but they had normalized with anakinra alone given for before 12 days of fever. Next slide, please. So in conclusion, body of experimental or biological data shows that anakinra can find its place in the treatment of Kawasaki disease, particularly with regard to improving the progression of coronary lesions. Anakinra use appears safe in Kawasaki disease if we refer to the ANAKIT trial. We still have many questions. So which patient should benefit from anakinra? When to start it? At first line, it's complicated by now. We need more evidence. Is there a window of opportunity to use anakinra, as we have seen with the experience in Still's disease? What should be the best scheme of treatment? which doses, we believe that it's rather high dose of anakinra what are really needed, but which should be the duration, the optimal duration? Should we use rather IV rather than subcut? And what is the optimal delay of response to treatment? With my experience, I see that on fever, anakinra can take a little more time than IVIG, but I believe really that it is a plus on the prevention of coronary lesion, and if they are present, it can have some effect in reducing their size. Of course, we need for an international effort for merging data on a retrospective way, but also on a prospective way. This is really important because it's very difficult to conduct clinical trials. Those patients are rare, they are small, and it is very difficult to have trials and to have an amount of patients which is sufficient to draw any conclusion. So I really thank you for your attention. Just the last slide to show you and to give you an announcement. Thank you.
Okay, thank you so much for the presentation. And we now enter to the question and answer session. So come on, don't be shy. I can't see any question. So maybe I can start with a question for you, Professor Kone-Paut. So in your opinion, based on your experience, what's the most effective dosing and route of administration of Kineret in Kawasaki patients?
So I think that we need to have rather high dose. I could say at least 6 milligrams per kilo, but maybe more, maybe 10, I don't know. For sure, I would, if I had to do another trial, probably I will try to use IV because it's more convenient to increase the dose and to have also stable concentration as it was shown in the ANAKIT trial. Because when you give it once a day, you can assume that after 6 hours, the concentration of anakinra decrease, and maybe we can have less effects than given but in IV. But also, I am also very conscious that it may be difficult to give IV during 14 days. So we have also to work on this and to know what should be the best duration. The shorter should be the best for sure.
We have one question from the audience. I think it's for you again, Isabelle. Thank you for the 2 fantastic lectures. Is there any role for using anakinra in KD cytokine storm syndrome? How to compare anakinra and intensified first-line treatment with the IVIG and steroid in high-risk patients?
So in a cytokine storm syndrome, I think it's even more interesting to use it. We have had some experience with MIS-C, and our team, but also other team, has shown that anakinra was really a very good option. I think it's very interesting in myocarditis, in acute myocarditis. There are some papers on this, so I don't know if it is especially because it's block both IL-1 alpha and IL-1 beta, and we know that it could be one thing of interest on this. So I think we have for sure also to pursue on this aspect because I think it's really an interesting option. I'm sure that Christophe could add something on this subject. And on the second question, I do not remember yet. What was the second question? Oh, yes, I remember. It was to use on first, yeah. You know, it was really a question I had when I started to draw and to design some trials. But the problem for me is when you do this, we will not be able to have the effect of anakinra alone. And so how we could label it after is use in addition to IVIG. So, you know, it's rather complicated. And to my opinion, if we want to have the effect of a drug alone, we have to do all the work using these open label studies and ever to have comparative studies using anakinra alone, and then move to on first choice.
Okay, thank you. We have two other questions from Alexandre. To Christophe, is there any lymphocyte activation marker that could be used to monitor the patients and decide for T-cell targeting therapy such as cyclosporine, for example? And for Isabelle, how do you use steroids in Kawasaki disease? And what do you suggest for the strategy with anakinra? Christophe.
Yeah, I can take that one quickly. Alex, thank you. I am not aware of a good marker that that could be used here. I mean, to me, the puzzling issue about the T cells is, I mean, they're clearly involved in the pathogenesis, but particularly in the periphery, I think the depletion of so many T cell subsets, I mean, it also complicates which cells to ideally look at. I mean, their recovery during IVIG treatment suggests that they're actually moving to the sites of inflammation, and maybe also from the coronary artery lesion single cell study, one might guess that looking for targeting markers of exhaustion may be something that could be interesting in this respect, but they do not address the fact whether this could actually have predictive power and inform about patients that would benefit from, as you suggest, the T cell targeted therapy.
Okay, Isabelle, I think it's your turn.
Yeah. So the subject of corticoids is very tricky. Of course, corticoids are very potent anti-inflammatory drugs. I think that in Kawasaki disease, it may have a role as an adjunctive therapy because it has a potent anti-inflammatory effect. I think that their effect on coronary disease is really debatable still. So it's very difficult. You know that corticoids have been recommended at first line as an adjunctive therapy for patients less than 1 year and that are high risk of developing coronary aneurysms. It's in the European recommendations, but it's not in the American recommendation. So I think it's really difficult. Personally, I am not convinced that really it is doing something on coronary aneurysms. We lack data, we lack good trials, and things that are really comparable. I am also conscious that biologics are not available everywhere, and we lack also good data for using them. So still good studies are needed, or data repository and a prospective way to compare different approach to see which one is the best. But it's really a very difficult question. I have to say that we are not systematic in our department for using them, quite less than maybe in other departments. And I'm sure that we don't have different results. So it's difficult to push for them, and it's impossible to say don't use them. So it's a very difficult question.
And I think this is really the hot topic because we have a question regarding this practical issue. We have Yusra El Fawayas that ask us if anakinra will replace IVIG as first-line treatment, and Yusuf Yücel asks us if in IVIG resistant patients is an option to combine IVIG and anakinra and and so IV anakinra.
Yeah.
So maybe a lot of study are needed in this field, especially for the practical aspect, how to treat patients, especially those who are at high risk and are resistant to first-line treatment. And maybe we have also some question regarding the first-line treatment, because anakinra seems to be a very good option.
Yeah, of cardiologists here, because we are really an important team of pediatric cardiology in Necker Enfants Malades. And for the very young, the 3-month-olds, 6-month-olds who are very inflammatory, and sometimes they have giant aneurysm after 3 days of fever, they use everything. So they combine IVIG, anakinra, and corticoids. And I think it's not a bad thing, because we have to do our best to avoid these incredible complications. So very difficult, and we have a lot to do.
Yeah, yeah. Okay, thank you so much to speakers and to my co-moderator, and thank you to all the audience for being here with us.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.
Thank you. Bye.